to talk about my experience on use of contrast intraoperative ultrasound. And that's largely because I've been working with the surgeons for the last 15 years, and I know what they like and I know what they don't like. And I'm lucky I've managed to prove them wrong over the years. But what I want to do in the first place is really give you the background as to why do we actually need intraoperative ultrasound or contrast intraoperative ultrasound. The background is really based on the colorectal cancer, and largely because this is the second most common cancer death in the Western world. And ultimately, half of these patients will have liver involvement. And liver resection is really the, according to surgeons, the only potential for cure. Now, we know, depending on different centers where you work, and obviously the more highly specialized one, the 5-year survival will range up to 60%, which is pretty good, considering what if you look at the natural history of the disease. Now, having said that, the vast majority of patients actually, despite the liver resection, will also develop recurrence, up to 75%. And liver involvement, again, is in the region of 50%. Now, what is interesting is that in this group of patients that up to 85% of these recurrences will appear within the first 2 years, which therefore means that if you look at the growth rates of these tumors, that these cancers have been there for these years, or even at the time of presentation, but it's just that our technique for identifying these tumors are just not that good enough. But nevertheless, I mean, we view intraoperative ultrasound as a gold standard for, God, many years, and to a lot of surgeons still is the gold standard. So it is quite clear that we do need better staging to be able to improve decision-making and hopefully the survival of those patients. And hence, I already showed you earlier on the benefit of using microbubbles percutaneously, and it seems quite obvious that we should be applying the use of microbubbles intraoperatively to be able to detect more tumors. But the difference is that there are significant differences between the percutaneous technique versus the intraoperative technique. The first thing is really in terms of the transducers. Most intraoperative ultrasound probe in the old days didn't have contrast capability. Very few companies actually do make intraoperative ultrasound probe with contrast capability, and I can name just about 2 or 3 of these companies. Now, these intraoperative ultrasound probes are high-frequency probes, and by and large, they range between 4 to 8 megahertz probes. Now, we talked about the limitations of these high-frequency probes in terms of picking up bubble sensitivity. So we have to bear that in mind. Now, if you didn't have those specialized high-frequency probes dedicated for intraoperative ultrasound scanning, you may actually use those percutaneous probes using a combination of both the high frequency for the near field area or the low frequency one for the deeper aspect of the liver. The reason is because a lot of the percutaneous probe, as you know, are end-firing. So therefore, unlike the intraoperative probe, you can't actually go underneath the liver after you've mobilized the liver to be able to scan the posterior aspect of the liver. So you need a combination of the two. And again, what I'm going to go through is some of the limitations of how, of the percutaneous probe in itself. But I think the first thing is really is the application of pressure. I mean, there's a tendency of us actually putting a lot of pressure on the probe when we're scanning. But intraoperatively, you shouldn't really do that, because what you do in first place, especially with microbubbles, is that you really destroy a lot of bubbles on the surface in the first place. And not to mention the fact that the compression really compresses the capillary and the whole thing. I mean, the liver, if you feel it in theater, it's like a sponge. You can actually squeeze it out completely if you want it. And by doing that, even in intraoperative, a lot of people make the mistake of applying such pressure that the lesions actually do disappear. Okay, so you've got to be very careful. So the other aspect I should really mention about the percutaneous probe is that you, by and large, do need a standoff. So therefore, you need to flood the abdomen with fluid to be able to get that standoff so that you actually can see the near field, the surface of the subcapsular lesions better. The second aspect is really getting the equipment settings correctly. And especially if you look using your percutaneous probe to do this kind of work, there's a limit to how low you can drive this mechanical index. Okay? Whereas with the intraoperative ultrasound probe with contrast capability, they can go as far down as 0.03 MI. Now, I was talking about these are very arbitrary, depending on which machine you're working with. These numbers may not mean a lot. So the answer is go as low as possible on the MI. And if you go as low as possible, you need to be able to counterbalance that with a gain. So again, like what Mike said earlier on, you need to be able to see a tinge of noise such that you're not really reducing the gain far too much or increase it so much that you get so much noise. The other aspect, again, I have to stress, is the focal zone position. Again, this is really to get uniformity throughout the whole screen while you're scanning. Now, what does a contrast which you use? And again, we talked about that earlier on, and in practice, what we would normally do is really kind of double or even triple the dose. I mean, when I say double or triple, normally in percutaneous scanning, I'm actually using only 1 ml or even less than 1 ml of the Centiview. Now, there's a particular reason for increasing the dose. It's not just because you're working on a higher frequency transducer, but also the fact that, you know, intraoperatively, those patients are under general anesthetic. And anesthesia in itself actually interferes with the bubble longevity and stability. So, for instance, what we know, I only found out from Bob Matre from San Diego, that the oxygen level is actually a very important component. And in fact, we actually did test that. So what we tend to do now, in fact, is actually during the GA, instead of keeping the patient on oxygen, we actually take them back on air, reduce the oxygen down before we do the injection. And it makes a heck of a difference in terms of the bubble longevity and aesthetics of the image itself. The other thing surgery should think about doing is also avoid using inhalation types of anesthetics. Again, because of the nature of the anesthetic itself, it will interfere, because remember, these are also some of them are perfluorocarbons, and therefore will interfere with the bubble stability. So this is really, by and large, the kind of protocol we would use. Now, it may be that one single injection is not going to be enough, but by and large, we use about 2 sets of injections to look at each lobe of the liver while we're doing the staging process. And this is usually done after the surgeons have mobilized the liver completely and done their palpation and all the rest. Okay? So what we went on to do is really to show you some of the kind of reason why ultrasound is useful to the surgeons and to us while we're doing this intraoperatively. Many of, you know, the traditional way of picking up metastases really back in the old days is by palpation. Tumors are very hard on the liver, so that's how the surgeon actually feels it. So he feels a hot lump, and he thinks it's a metastasis, right? But as you can see here, the palpation is being done underneath there. There is a tumor there, but you just can't see it, right? And yet, if you put the bubble in, and you keep your finger there, you can see the big filling defect. It's not like these are small tumors. These are big tumors. So how you handle the liver in itself, even with the addition of conventional intraoperative ultrasound, you may still miss it if you don't have contrast. But you can see the difference with the presence of microbubbles. Now, some of the lesions, again, it's not just the small lesions we miss. I want to show you some of the big lesions you may actually miss. Now, the only reason why you're seeing this lesion here is because of the halo that you can see around that, okay? And also the fact I've already shown you the picture on the other side. But you can see it's so much easier. The contrast between liver tumor and, the metastasis and the liver is daylight, really. Not to mention, and Hans-Peter's already said, that we can pick up lesions really down to 5 millimeter, even smaller, up to 3 millimeter. But again, that depends on the resolution of your scan in the first place. Now, and this is another assumption. All the lesions that you find are actually malignant. We've seen so many mistakes made by CT scan with benign lesions misdiagnosed as metastasis when they actually hemangiomas. But this one is actually an AVM. In fact, the surgeon called me and says, I can't see the tumor. I've been scanning and scanning, I can't see the tumor. In fact, this is just an AVM, right? You can see this is just a vascular structure. So in reality, what happened was that, just about to resect the whole thing. So what surgeons tend to do is, they go strictly by what the CT is already shown, irrespective of what they find sometimes, because they kind of confuse, open up. There's nothing worse. CT has already said there's a tumor in this segment. If you don't resect it, because you can't see it, and then if you were to do scanning afterwards, it's so much more embarrassing. So they actually go on resecting it according to what the preoperative staging have shown. So hence to show you the importance of actually doing the scan intraoperatively. So what I'm going to report is really a study that we did. Got some time, quite some time, because some of the images, as you can see, I've got ATL marks on it. So this is, the reason is because ATL in those days were the very first intraoperative probe, which is the CT84, which actually had the contrast capability. And as you can see also, that was pure pulse inversion. That's not power modulation or PMPI. Those were the days we were using PI. But looking at the bar chart from the study that we did, it was, I think, a cohort of 90 patients. We compared the preoperative CT-MR combined or alone versus the intraoperative ultrasound scan and versus the contrast-enhanced intraoperative ultrasound scan. And as you can see, the sensitivity of the modalities is incremental as you go more invasive. The intraoperative ultrasound ranges in the 85.4% versus the 74% for the preoperative CT-MR. But CEUS in itself, the sensitivity was 96 or 97%. And again, the gold standard here was from the resected segments and with pathological analysis, and also any of the additional lesions whereby we didn't resect, these patients had biopsy. And we translate the accuracy in terms of not just the detection, but also in terms of characterization. Again, the contrast-enhanced intraoperative ultrasound is far more superior compared to the intraoperative ultrasound, and more so than the CT-MR. Now, the reason why I mentioned the detection and characterization component is actually quite important. From the point of view of metastasis, colorectal cancer is very straightforward because it's just a question of detection. Yeah, and you got this 15–20% of cases whereby there's a possibility that it's actually maybe benign. But within the context of cirrhotic livers, which I'm not really talking too much about, but I'm just really showing that the emphasis is totally different when you look at cirrhotic livers when they have these patients go undergo liver resection, is that it's most from the point of view characterization rather than detection for cirrhotic livers. A lot of surgeons that have bigger practices on cirrhotic livers for hepatocellular carcinomas, what they tend to use the intraoperative ultrasound contrast capability is really from the characterization point of view. Nodules are loads of nodules. What they want to confirm is the one they're going to resect is actually the hepatoma. So that's the difference between colorectal and the HCCs. Now, it's fine we talk about differences in sensitivity and differences in accuracy, but more important from the patient's point of view is to what extent does it actually influence their management. And intraoperatively, so we look at the impact on management on the cohort of patients that we talked about. Right at the operation, there were a group of patients. There were patients that already didn't need intraoperative ultrasound, largely because they were riddled with tumors. But if we look at the cohort of patients, the remaining cohort of patients, 87 patients that we did contrast intraoperative ultrasound, there was no change in management in the vast majority, which is the 62 of these patients. That's equivalent to 71%. And even in that group, 2 of these patients had additional lesions. One was wrongly diagnosed, was a wrongly diagnosed hemangioma as metastasis. But the change in management in our cohort of patients was 25 out of the 87. That's equivalent to nearly 29%. And the vast majority was really in terms of additional lesions detected in other segments that were not being planned for resection. And in some cases, actually, there were less lesions as compared to what CT-MR or intraoperative ultrasound was showing. And the one vascular case I showed you was the AV malformation. And again, in 3 of these patients, it turned out to be benign lesions. But overall, just from the point of view of imaging staging, the change was in the region of 32%. That was in 28 of patients, which is significant numbers. And considering that these liver resections are actually fairly, expensive kind of procedures. Now, so what did we do about the additional lesions? Well, we went on to actually just do ablation with guidance under the contrast enhanced intraoperative ultrasound. And that we did in 14 of the cases, which is really the vast majority of that group of patients. What is the experience elsewhere? And I guess Torzilli is really the second group in I think it's Milan, that has the largest experience, especially on patients with cirrhotic livers with hepatomas for resection. But they also look at a small cohort of patients with colorectal cancer, and they picked up additional lesions in 4 out of 24 patients. And what they also mentioned that the fact that given that the contrast delineates the metastasis much better, therefore helped them in looking at surgical resection margin much more accurately, and that happened in 29%. Now, the first study I showed you was purely based on Synoview, but we also wanted to reproduce the data using a different contrast, which is Definity. This is what's now called Luminity, and that's what's licensed in Canada for radiology. That's the other name was DMP-115. We did this in 37 patients with colorectal cancer, and again, we got more or less the same kind of results. At a lesional level, certainly the sensitivity was higher with the contrast than compared with our contrast. It's 95% versus 67%. And at the patient level, and again, it was more in 84% versus 74%. And change management, again, was lower, and I guess different patient population, slightly smaller cohort of patients, and that might explain for the difference, and it was only in 21% of patients. Now, other centers had tried to do the same thing with Synoview. Bram, in 2008, reported on 39 patients with colorectal cancer, but they only picked up additional lesions in 2 of the 39, and only 1 change in management. There was no difference in the accuracy between any of the modalities. Now, the only explanation I can have for the differences, what they're showing compared to what we're having, is perhaps twofold. It's all based on patient population, and also how aggressive is your surgeon is prepared to do. You may have surgeons that are only prepared to consider patients with only 1 lesion, whereas if you have a very aggressive kind of approach to cancer care, you may pick up, you may do a lot more, try to do more resection on patients who got more advanced disease. So numbers, you've got to be careful. It has to be within the right clinical context. And I suspect one would say that that perhaps is probably based on patient population. We've got very little, the extent of disease in the liver is much less compared to what we were trying to do. We certainly had very, very aggressive surgeons who would literally operate on anything. So it all depends on your patient population. But I think the other aspect, perhaps technical aspect, one should look at is perhaps comparing the use of intraoperative ultrasound, a proper dedicated intraoperative ultrasound probe versus a percutaneous probe that you use intraoperatively. And there are key differences. And that requires a bit of expertise to be able to use the percutaneous probe, apply it intraoperatively, and knowing to swap between the high frequency and the low frequency probe. So that may be another reason. Now, the other study which is interesting is really the one by Nakano, and that's a really early stage, largely in the sense that they were looking at only 8 colorectal cancer, and they were, and Salazar and as Peter, as well as David mentioned, is quite an interesting contrast, given that this is a liver-specific contrast, and hopefully we'll get to see it in Europe and do more clinical trials and see the true value in terms of intraoperative ultrasound. And they seem to be quite happy picking up more lesions, but again, I said to you, the numbers are so small there. But there are potentials for us to improve. Remember, Synoview is not a dedicated, proper liver-specific contrast, whereas this one is. And I'd love to see what this particular agent does in our practice in the future. So to summarize, I don't think there's any doubt in our experience that it is this technique is an essential tool for all liver surgeons. I'm not aware of many centers actually routinely using contrast-enhanced intraoperative ultrasound across the UK, but it is something certainly we would like to see used routinely, given that given the results that we've seen. But I think in addition to that, having said, being able to detect those occult tumors, right, will allow us also to immediately change our approach by putting adjunctive ablations, whether it's RF or microwave or cryoablation. The true impact of the bubble is not so much how it also changed surgical management. Well, it is important in terms of the economics of it, because, you know, this is expensive procedure. You want to make sure that you resect as many tumors as possible. But I guess the ultimate measure of the true outcome, the true value of the modality is whether this practice actually improves the patient survival. That, I guess, we'll never know. I mean, it will take a very tricky study to really pinpoint the true value of the bubble in terms of prolonging this patient survival. Not to mention the fact that a lot of these patients don't just get one treatment. I mean, the vast majority of these patients have liver resection now, almost automatically go on adjuvant chemotherapy. Especially now that we have so many good regimes, especially in colorectal cancer, it's almost automatic that these patients. So we will probably never really know the true value of the bubble being able to identify more tumors, therefore we'll resect more. But I think in general, if you accept the concept, it is still better to be aggressive than non-aggressive. Okay, so I think this is a key point. Where does the future lies? We've seen that, you know, it's not 100%. We can pick up the 5 millimeter or 1 centimeter lesions, but there are going to be micrometastases. The micrometastases are always going to be an issue. We don't know much about, you know, the true natural history of a lot of these micrometastases. Why they're dormant, why do they react, why do they reactivate, why do they grow in some patients, they don't grow in other patients. So there's a lot for us to learn. But I'm thinking more from the technical point that if you can't achieve some stuff intraoperatively, perhaps by looking at fusion imaging and navigation, especially when we get to the molecular imaging modalities, which is better than ultrasound, that might actually help us to do this intraoperatively as well. Thank you.